Testing, 1, 2, 3. Can you hear? Testing, 1, 2, 3. Testing, 1, 2. Can you hear that?
I can hear it. Hang on 1 second, I'm gonna adjust it.
No, I think she just turned it on.
Go ahead, try it again.
Testing, 1, 2, 3. Testing. You good?
Perfect,
Okay.
thank you.
Witness mic 1, 2. Ask everyone to take their seats, and the Subcommittee on Health will come to order, and I'll recognize myself 5 minutes for the purpose of an opening statement. And I want to thank everyone for joining us for this important and long-awaited hearing in 2018. It's on. I'm just not speaking into it. In 2018, is it on now? Is, well, come on up here. There's space on the top dais. In 2018, we've held two Cures implementation hearings, including focusing on biomedical research and innovation at the National Institute of Health and the Food and Drug Administration, and a hearing on the mental health title. Today's hearing completes the 21st Century Cures trifecta, covering the last remaining title, Health Information Technology. Our society, our economy have become increasingly driven by technology, and healthcare, of course, is no exception. Electronic health records, patient data, the move to open application programming interfaces, and other developments have brought healthcare into the 21st century. Law lagged behind such advances, which led to various pieces of legislation to address the aforementioned issues, including the HITECH Act in 2009 and 21st Century Cures Act in 2016. Cures built on top of the foundation laid by the HITECH Act, which passed in 2009 and encouraged adoption and use of electronic health records through payment incentives and penalties. For the record, I opposed that. This law also established the Office of National Coordinator for Health Information Technology in statute. Previously, it had been via executive order, but the HITECH Act established that in statute, signifying the importance of health IT in the future of healthcare data and delivery. Some argue that HITECH was well-intentioned. Stakeholders have reported concerns during implementation related to the interoperability and functionality of this technology. While we have seen widespread adoption of electronic health records, there does continue to be significant fragmentation in the healthcare system, making it difficult to ensure continuity of evidence-based care for patients. The 21st Century Cures Act has set us on a path toward achieving this nationwide interoperable healthcare information system, and the idea is to put the needs of patients and providers first. The first health IT provision in Cures was aimed at assisting doctors and hospitals in improving the quality of care for patients. One goal of this provision was to reduce the burden on physicians regarding electronic health records. As the Office of National Coordinator moves forward, it is of utmost importance that it take into account the impact of policies on both patients and physicians. Section 4003 of the Cures Act expedites interoperability and security among electronic health records through a voluntary model framework and a common agreement among vendors. The Office of National Coordinator released a draft of this Trusted Exchange Framework and Common Agreement in January of this year. Today, the National Coordinator for Health Information Technology, Dr. Don Rucker, will explain the common principles that will guide health information networks, recognize coordinating entities, and others through the exchange of data. The Office of National Coordinator also has sunset the old Policy and Standards Committee, to which I say good riddance, because they were quick to chase any issue that sparked their attention. Instead, a new interoperability committee has been set up that will with clear guidance from Congress to focus on interoperability, security, and privacy. Another theme throughout the Health IT title of 21st Century Cures was patient access to data. While electronic health records are critically important to physicians, it turns out they're equally important to patients, and it's important that patients have access. Cures required the Department of Health and Human Services, in coordination with the Office of Civil Rights, to educate providers about lawful patient health information sharing. The Get It, Check It, Use It program shows patients how to access, update, and use their health information appropriately. The reason this hearing was delayed was there is a rule required by Cures that will cover several items, most notably the rule regarding information blocking has yet to be released. I believe it is currently awaiting approval by the Office of Management and the Budget. So Dr. Rucker will be unable to address the pending rule. It is important to note that the Cures legislation defined and prohibited information blocking while in fact levying civil money penalties on those who engage in information blocking. The Office of National Coordinator rule will define what does not constitute information blocking, therefore outlining what is permissible. I'm extremely disappointed that after 2 years after the passage of Cures, we still do not have the regulations necessary to implement these provisions. It is hard to explain to people that Congress provided the tools necessary for doctors and patients to better coordinate their care through the sharing of patient data, but nothing has changed. I'll submit the balance of my statement for the record and recognize Mr. Green of Texas for his opening statement, please.
Thank you, Mr. Chairman, and I'd like to thank you for calling this hearing in the continuation of the oversight over the Cures Act, which, along with the Affordable Care Act and Cures, is probably the two major pieces of legislation in my 26 years in Washington. And I'd like to thank Dr. Rucker for testifying today on the Office of National Coordinator's work to implement the 21st Century Cures Act. In a little over a decade, the Office of the National Coordinator has helped to drive the rapid adoption of electronic health records, EHR, in doctors' offices and hospitals across the country. Today, nearly all hospitals and 3/4 of the office-based physicians use some form of certified EHR technology. This uptake has allowed for improved communication and patient care, but we still have a long way to go in ensuring that EHRs are as useful as possible to providers as well as easy accessible and understandable to consumers. The Cures Act aimed to build on the progress of the HITECH Act of 2009, but by focusing on improving interoperability, patient access to their health records, and reducing provider burden. For example, Cures Act asked ONC with a task with providing examples of what does not constitute information blocking. This information is a critical part of the law's implementation and will inform the Office of the Inspector General's enforcement regarding information blocking. I look forward to this proposed rules release. The Cures Act also called for the development of Trusted Exchange Framework and Common Agreement, TEFCA. This framework outlines the minimum terms and conditions providers should meet in order to securely and appropriately exchange information with each other. Setting clear parameters around exchanging information is necessary for widespread interoperability. I'm pleased to hear that ONC is undergoing a rigorous public comment process before finalizing this provision. In addition to improving interoperability, we need to increase consumer education so folks understand that they have a right under HIPAA to obtain access to their records and to decide who their records should be shared with. I'm glad that ONC has partnered with the Office of Civil Rights to release new information for consumers on HIPAA's patient right to access. Increased interoperability and better high-tech in general has a potential to improve every American's healthcare experience. So I hope that ONC will continue its implementation of the law in a timely manner. And I'd like to yield the balance of my time to Congresswoman DeGette.
Chair, thanks. Gentlelady, the gentleman yields back.
I yield back, Mr. Chairman.
Not seeing the chairman of the full committee here, be prepared to yield to the gentlelady from Tennessee, the senator designate from that state, because I know this is an important issue in Nashville, in your part of the world.
Thank you so much, Mr. Chairman, and thank you for the good work that you have done in leading this committee over the past couple of years. We appreciate that, and we're thrilled with 21st Century Cures being signed into law. And as the chairman said, Middle Tennessee, which is home for me, is home to over 400 healthcare companies. And while many people rightfully think of Nashville as Music City, USA, and indeed it is also the center of much of the healthcare management and healthcare delivery in this nation. And you see these 400 healthcare companies that are located there working not only in hospital management, but in insurance products, home health, hospice, you name it, every single sector of the healthcare industry. You also have some nonprofits that are working on how you deliver better patient care. One of those is the Center for Medical Interoperability, which is located right in Nashville and is looking at that intersection of healthcare technology, healthcare informatics, predictive diagnoses. And we were so pleased with the Software Act provisions, which Mr. Green and I authored, being included in 21st Century Cures, and then the follow-on implementation of this through the FDA, and the implementation that you at ONC are overseeing. So we're watching that very closely because we know of the impact that that has on care coordination, that it has on post-acute care, that it has on managing and following chronic conditions, and that it also has on home health. And we know that this impact is going to be felt. So we thank you, Dr. Rucker, for being here to give us an update. Mr. Chairman, I thank you for the leadership that you have provided. And at this time, I would yield to any other member of the subcommittee seeking time. No one seeking time, I yield back, Mr. Chairman. Thank you.
Chair, thanks, the gentlelady. Gentlelady yields back. Not seeing the ranking member of the full committee here, is there anyone on the minority side who wishes to claim the time? If not, that will conclude member opening statements. And the chair would like to remind members that pursuant to committee rules, all members' opening statements will be made part of the record. And we certainly want to thank our witness for being here today, taking time to testify before the subcommittee. Our witness will have the opportunity to give an opening statement followed by questions from members. And today we are going to hear from Dr. Donald Rucker, the National Coordinator for Health Information Technology from the United States Department of Health and Human Services. Dr. Rucker, we appreciate you being here with us. It's been a long time coming, and you are now recognized for 5 minutes to summarize your opening statement, please.
Chairman Burgess, Ranking Member Green, distinguished members of the subcommittee, thank you for the opportunity to testify. Since its start in 2004, ONC has worked to improve the quality, safety, and efficiency of healthcare. While hospitals and physicians have made great progress adopting electronic medical records, additional work is needed to increase the value of these records. Clinicians often spend hours a day at the computer. The Cures Act asks HHS to address clinician burden related to electronic records. In November, ONC and CMS released a draft strategy to reduce administrative burdens. We have worked with CMS to address burnout, changing documentation requirements, and simplifying reporting. The Cures Act directs the Secretary to adopt policies to increase the trusted exchange of electronic health information. ONC has developed a proposed rule to support this exchange of clinical data. As requested, the rule will implement the Cures Act prohibition of information blocking by defining allowable exceptions. We want patients to get their medical records on their smartphones. We want consumers to shop for care on their smartphones. To do this, the Cures Act calls for EHR developers to publish application programming interfaces, APIs, that permit secure access without special effort. We expect an app marketplace will evolve with products for both illness and health. Recently, Apple introduced their health record app using the RESTful JSON and FHIR technical interface standards. Now over 100 health systems provide patients their data here. ONC has been instrumental in advancing the healthcare part of these standards. Some of our stakeholders have shared security concerns with a requirement to publish APIs. We take cybersecurity threats seriously. It is important to note that in general, APIs are not usually where security vulnerabilities reside. The OAuth standard used to authorize exchange through open APIs, and these are secure open APIs, provides robust security. Security breaches often reflect password issues or servers with unpatched operating systems. Secretary Azar has identified value-based care as a priority. The ability to analyze health outcomes for an entire group of patients rather than just one individual patient is essential to identify providers with the best value. Today, payers and employers have little information on provider performance. Often payers are forced to negotiate contracts with hospital systems based on network consolidation rather than value. ONC is working with the HL7 Standards Group and insurers to build APIs that truly measure care. ONC is also working to increase connectivity among health information networks. There are about 100 regional and national networks which exchange health information. While these organizations have made significant progress, connectivity across networks has been limited due to variations in technical and data use agreements. The Cures Act directs ONC to, quote, develop or support a trusted exchange framework, including a common agreement among health information networks nationally, unquote. In January, ONC released the first draft of the Trusted Exchange Framework. We will release an updated draft for further public comment. The Trusted Exchange Framework can also support community information exchange. There is limited interoperability for patients with mental health or addiction illnesses. These patients move between emergency rooms, shelters, group homes, and treatment centers with little awareness of how often and how ineffectively these expensive services are being used. Regional health information exchanges are ideally positioned to link these patients and services. In summary, ONC has made great progress implementing the provisions of the 21st Century Cures Act. We believe the proposed rule for open secure APIs will, with the Trusted Exchange Framework, allow patients to get their medical care on their smartphone and to control the care they receive. We will continue to keep Congress informed. Mr. Chairman, Ranking Member, members of the subcommittee, thank you for the opportunity to testify. I look forward to questions.
Well, thank you, Dr. Rucker, for your testimony, and we will move to the question portion of the hearing. And I'd like to yield my time first to the gentlelady from Tennessee again for her questions.
Thank you, Mr. Chairman, and I do thank you and your team for the work that you all are doing. And, you know, in this town where they say there is no bipartisanship, I think that we would all say 21st Century Cures and working together, getting that across the finish line so President Obama could sign it was one of the stellar accomplishments of our work here. You touched on privacy, and that is what I want to discuss with you because so many of the mHealth apps contain the most sensitive of information about us. And every day as I am out working in my community or going to the grocery store or going to church or, you know, at even a basketball game with my grandsons, somebody who is working in health technology will tell me about something that they are working on that is going to improve patient care in some way, shape, or form. But we've had the Browser Act, which would require individuals to opt in to share their sensitive information, and then they would have the option of opting out for non-sensitive information. So as you look at the utilization of the mHealth apps and the plethora of these that are now in the marketplace on both the non-sensitive and the sensitive information, talk to me a little bit about how you see HIPAA evolving, how you see privacy policy evolving as it affects our healthcare data.
All right. So
I know it's a lot to unpack in that.
yes. Obviously, I think first and foremost we have to protect privacy, right? So we have to think about what the software approaches are that protect privacy, and there are folks who do a very good job at that. If you look at, for example, the banking industry, the brokerage firm, there are some people who really have nailed the privacy stack. Right now, if you look at the mHealth world right now, I think there's actually a fairly stark divide between the apps that have access to clinical information and then apps that don't, right? So, classically the Fitbit type of app. I think part of, and my understanding of Cures, part of it is to actually allow some merger of these things so that patients' clinical information can ensure their broader health choices and not have this divide. As soon as we get to clinical information, we have to work with HIPAA. HIPAA, I think, is a very powerful, very straightforward rule that I think sets a very nice bound on privacy. There is absolutely nothing in ONC's activities that requires changing HIPAA. And so we follow HIPAA. We think it's actually a very solid rule to protect privacy. So there's a combination of technology on the security side. Clearly, the tools to really fully inform patients and truly get rich consent, I think some of this is honestly still a work in progress. I mean, we can look at specific things, but I don't think we have fully solved the full communication of how patients share information. That may be broadly true, throughout the app economy. We believe what we're doing in the rule will empower patients with fairly precise ability to control their information.
Thank you. I yield back.
Gentlelady yields back. Chair thanks the gentlelady. Chair now recognizes the gentleman from Texas. Mr. Green, 5 minutes for your questions, please.
Thank you, Mr. Chairman. Again, Dr. Rucker, thank you for being here. The 21st Century Cures, we made a number of changes from the HITECH Act to address clinician burden and encourage communication between providers. What progress has been made to date with these changes to the 21st Century Cures Act?
Yeah, there are a number of things, Congressman, that have happened already. So one of the provisions in 4001 is to actually start by identifying what those burdens are. So we have released recently a draft report out for public comment on a 70-page report listing what we think the main burdens are on physicians and other providers. These burdens come in a couple different areas. I think the top level, documentation, some of the things around quality reporting, some of the things around just raw usability, which in and of itself is a very complicated issue. Things like prior authorization come into that. In terms of what has been done, pleased to say, and this report was done jointly with CMS. So working with CMS, we have had the first reconsideration of documentation requirements since the 1995 CPT things, trying to reduce re-entry of data on, parts of the history that aren't changing. So reducing re-entry of data and flattening some of the economic incentives in the CPT coding system to do all of the boilerplate text that infiltrates all of the notes in America when you actually, and I've been a clinician for 30 years, actually have to find out something about a patient and wade through this template-generated text. There's more to be done there, but I think literally the first effort at fixing this since 1995. CMS, and we've been part of that, has also simplified a number of the requirements around what was formerly meaningful use. clearing up things there and focusing on promoting interoperability to have a much more constrained set of reporting requirements. So those are some of the things that we've done directly out of the Cures Act.
Information blocking is a topic ONC's been examining since even before we passed the Cures Act. In fact, in April of 2015, ONC released a report on information blocking in the healthcare sector. In this report, ONC describes information blocking as when persons or entities knowingly and unreasonably interfere with the exchange or use of electronic health information. That definition alone, without additional context, creates a great deal of uncertainty about the specific practices that are considered information blocking. That's why Congress asked the ONC to draft a proposed rule providing more detail on what may or may not constitute information blocking. Unfortunately, this rule has still not been released, and I know your ability to discuss the content of the rule is limited, but Dr. Rucker, can you share with us some of the research analysis that went into the development of the rule?
Yes, so what information to share is obviously one of the most complicated issues when you think about the vast amount of clinical information that floats in the care of a sick patient, in the care of, all patients. We're looking at things like images, we're looking at lab tests, we're looking at notes, we're looking at consults. I mean, that's just scratching the surface. There are, dozens and dozens and dozens of types of information. Now we're looking at some of the prescription, opiate prescription, so lots and lots of information. It's a large world in terms of who potentially has information, who could share it. So our analysis has been focused, to understand the breadth of that from a legal, from a rulemaking perspective to make sure we get it right the first time, as opposed to sort of putting stuff out that's a little bit, that needs a lot more further work. The areas that I think you can anticipate, that have come up in this research are things like, first of all, just being in harmony with existing state laws, right? There's a lot of privacy laws, and so we have to think about that. We have to think about security issues. We've just asked a question about privacy and security. We have to think about cases where patients have deep mental illness, where there may be some information issues. Frankly, we have to think about what can be charged. We've, heard where the information is blocked simply by charges to share that information that appear not to be related to any observable software development costs. So those, Congressman, are the types of considerations that we have to consider in putting out the exceptions that we're asked to put out the exceptions, as you've pointed out.
Thank you, Mr. Chairman. I have some other questions I'll submit. I know I've run out of time.
Gentleman yields back. Chair thanks. Gentleman, Chair recognizes the gentleman from Kentucky, Vice Chairman of the subcommittee, Mr. Guthrie. 5 minutes for questions.
Hey, thank you very much. And I do want to echo, I'm going to miss Mr. Green. He's been a good person to work with as Vice Chairman of this committee. And I'm going to miss you and the leadership of the chairmanship for a lot of reasons, but you've done a great job, Mr. Chairman. Really appreciate your work as well. I have some of the concerns that my friend, the future senator the next senator from Tennessee, I guess I should say, not future, the next, about privacy. And one of the things that I'm working with my friend, Ms. Matsui from California, we've worked to recently introduce a bill related to developing federal policy on blockchain technology, just trying to figure that out. So if we look at hardware and software, regulatory reform, and completely new technologies like blockchain, just so much is changing, as we're getting at. Where do you see the future of healthcare information going, and what can we do to best protect Americans' most sensitive information?
I think when you look at the protection of information, I think there's actually 3 areas to unpack here from a, if you will, a somewhat technical point of view. One is the authentication. So when you log on, are you actually the person you say you are, as opposed to somebody in, some rogue agent? So that's authentication. The second is authorization, right? Are you, now that you've logged on, are you allowed to actually get this information from the point of view of the provider? And the third is from the point of view of the patient, consent, right? And so these all actually have, especially authentication, have some very, very interesting technologies out there. I believe that the advance in technology is going to make some of these things materially easier in healthcare. Let me give you an example. It turns out today that pretty much you can authenticate anybody from their ownership of their cell phone, right? And even if some rogue agent gets your cell phone account number and tries to switch it out, there is so much information in just how you've configured your apps, where you use the cell phone, how you use it, how you swipe on it, that there are a number of companies out there that can authenticate to a very high degree. I'm told a lot of the financial services industry uses that. So I think the broader technologies on security are getting much better. One of the things that we're very focused on at ONC is making sure for the critical security and privacy things that we don't cook up healthcare specific things that will then make healthcare more vulnerable because they're more outdated, they haven't kept up with the most modern technology. So as you hear us talk over time, we're very conscious to try to have the best security tools that are out there and not inadvertently do any type of policies that prevent that from happening. Hopefully that gives you a bit of a flavor of how we unpack that.
Thanks, thank you. And also, in your testimony, you mentioned that payers and providers should negotiate contracts based on quality, and I couldn't agree more. Can you please explain ONC's role in collaborating with payers and providers on developing standards? The question is, how do you determine the quality? That's where we role in doing that.
Yes. So, and this was a bit of a surprise to me, which from just my clinical experience as an ER doc. Right now, when you talk with a lot of the large payers, they actually they get the claims data very rapidly, right? So that's all electronic and pretty much instantaneous. It's actually very hard for them to get clinical data. So typically, if they want to get clinical data, they can either in the network contract negotiate that there are queries, so database downloads, very narrowly defined, predefined, or they can go out and download the entire record at cost, I'm told by some of the largest payers in the U.S., of between $4 and $6 per chart, right? So at $4 to $6 per chart, you can't actually be downloading everybody's record that's prohibitive from a cost point of view. In working with some of the research folks we've worked with and the payers pretty much simultaneously, it turns out that the new FHIR standards that we're implementing, that the whole healthcare ecosystem is very excited about and is implementing, can be extended to get a population of patients, get that data. This is critical for things like the learning health system. It's critical if we're going to have payers figure out what they're getting from providers. So it's really having the ability to use all the big data things we're talking about from a computational point of view is what that's about. And we work very tightly with them. We have a whole standards group that works on that. Steve Posnack, who's right here, leads all of that work, I'm pleased to say.
Okay, thank you. Appreciate your answers. My time's expired. Now I yield back.
Gentleman yields back, Chair. Thanks. The gentleman chair recognizes the gentlelady from California, Ms. Matsui. 5 minutes for questions, please.
Thank you, Mr. Chairman, and thank you, Dr. Rucker, for being here. This is a hearing that I've been looking forward to. There's several of us working on the telehealth working group, and we really believe that this attention has to be paid on, particularly in telehealth, because we know that not only is information sharing important, but also the security aspects of it, and we also know that we want the patient to be able to access a lot of this information, and the providers. The healthcare providers face an onslaught of cybersecurity threats. I think a June 2017 healthcare industry cybersecurity task force report went so far to identify healthcare cybersecurity as a key public health concern that needs immediate and aggressive attention. Now, with that in mind, I am really concerned that as data moves more freely and becomes interoperable, which we want, there may be more opportunity for bad actors to compromise this data. While open APIs may be common to the tech space, standards aren't in place for healthcare. And I'm particularly interested in this because healthcare, the information provided in healthcare is very, very personal to an individual, and in particular, as we also talk about mental health too, because there's still a stigma attached to some of that information. So, Dr. Rucker, what is ONC doing to enhance the cybersecurity readiness of healthcare providers as we encourage more data to be shared across the healthcare ecosystem?
Yeah. So I think there are a couple of things. I think, first of all, as a background, we're very mindful. The biggest cybersecurity risk in general is just system complexity, right? When you just look at it, it's the built footprint, it's the number of passwords. That's the biggest risk. So we're, just mindful. Are we, increasing system complexity in, quirky kind of ways? The Open API, honestly, in some ways, is a bit misnamed. It should really be a very secure API. It's like, it's the difference between a door that's open and a door on a bank vault, right? There's a lot of protection on that. We're really talking more the door on a bank vault. The OAuth 2 standard, so there's a very tight sort of three-way standard that authenticates patients to make sure that it's them and that they're getting that data and that is being transmitted securely. So those are the policies that we encourage, and in our rulemaking, you will see those high technology standards to actually provide all of that security on access and transport. So that's the technical answer. I think the broader answer is we just have to be very mindful of this. The mental health issues are huge. All of these issues, and of course, it's forever, right? When something gets out, there's no way to retract it, right? It's literally forever. I think there will be, over time, an evolution of how patients think about their data. There's clearly an education task on what apps patients would allow to access their data that I think is out there. So there are a bunch of components, and again, there may be some interesting new technologies to allow that.
Okay, then what is ONC doing to ensure that consumers understand their rights, specifically when a person's data is transferred from a health system to an app of their choosing using an API, that the data is no longer protected by HIPAA? I know HIPAA came up before, but
Yes.
It's really sort of the standard that we have. And we've had discussion before, particularly in the mental health arena. And it becomes somewhat more complicated because the individual themselves may not be able themselves to understand what this really means. So I am curious because there's many, many layers to some of these APIs that even if people give some consent, they really don't understand.
Yeah. Well, this is evolving, but in the initial go-around, we're trying to make it a very conscious process where patients actually have to get authenticated by going back to the portal, right? The challenge here, the first challenge is how do you authenticate? So we're making it a very conscious process. This is not one of these things where you just sort of click, we've all clicked through consents, right?
Right.
There's nobody here who hasn't clicked through who knows how many consents. With GDPR and all of that, it's every day, right? Click through consents. We're making this a very conscious process so people understand the authentication, let's say there's an app that they want to use. They have to go back to their provider and authenticate to get that transfer. So it's really a three-way party thing. So we think it's a very conscious thing as a start. So nobody's just accidentally clicking through the way we do on much of the rest of our lives.
Okay.
I think that's
Right.
a big part of it to start. And then we're working with our community on what that information is. We've done various things with the Office of Civil Rights, with SAMHSA, in terms of mental
Right.
health to sort of propagate
So
an understanding of
what
that.
you're basically saying is a work in progress as of this moment right now.
I would say the long-term public use of their data is definitely
Right.
a to be determined. We're putting it out. the rules we're putting out are to allow it securely, but, you know, how that, you know, what the public take on that is, you know, it's, you know,
Right. Well, I see, I've gone way over, so thank you very much.
thank you.
Gentlelady yields back, Chair. Thanks, the gentlelady. Before I recognize the gentleman from Ohio, I do want to point out that it was a visit to the gentleman's district 5 or 6 years ago when I spoke to your medical staff section, when many of these problems with interoperability were really brought home to me in a way that had not previously been disclosed. And the intensity of that exchange that morning is one of the things that I've carried with me over these years, which actually has led up to the language in the Cures bill, a previous interoperability bill that I had done. And now I'm pleased to recognize the gentleman from Ohio. 5 minutes for questions, please.
Well, thank you very much, Mr. Chairman, and I want to thank you not only for coming out that time, but you've come out to the district twice to speak with folks in the healthcare community, and it's by having that personal touch, you might say, is where you get this, really what's going on with the professionals out there and the other individuals in the healthcare industry are facing. So I appreciate that. And if I could also take a quick point of personal privilege to thank the ranking member, the gentleman from Texas, for all your years here on service on the committee, and also on all the different pieces of legislation that we've worked on together. I just want to thank you very much for your tenure and best wishes in the future. So thank you very much.
I appreciate the working relationship. My most fun was that when we worked across the aisle, both our leaderships were worried about it. So thank you.
But it always turned out. But thank you very much, Dr. Rucker, for being with us today. And, you know, you've been hearing quite a bit of the questioning, especially when we're talking about cybersecurity, and because just in fact, the majority staff just put this out last week, which is our cybersecurity strategy report that came out on December the 7th. And we've done a lot of work on this committee on cybersecurity. But I'd like to go back, just if I could, just to, because there's been a lot of questions on the cyber side. But you were talking about some of the problems that you looked at with cybersecurity and how there's going to be, because the subcommittee I chair on digital commerce, we had a hearing that involved a lot of people that had been breached, and it was because of a question about something hadn't been patched. But you talked about something, you just mentioned about something having been unpatched, but by some providers. How do you look in the future that, you know, you through your group with ONC and HHS can make sure that these things get patched? Because that's one of the problems we have out there. If, you know, there can be a cure real quick, but if it isn't done, isn't followed, then we have a massive breach out there. So how do you, you know, because it's you know, you could talk about the voluntary, or you could talk about maybe more of a forced approach, but how you're going to encourage these things to be patched.
I think, you know, part of it is just, I think people have more and more awareness of this. I think, you know, so I think there's that out there. There's actually a, you know, we have specific provisions on the Medicare side and payments with promoting interoperability that folks have to do a security assessment. So we're actually asking providers, or requiring, you know, asking is I think a nominal term when there's federal incentives and disincentives involved, but we're actually in that program asking providers to do a security analysis, just to sort of a self-awareness, to be aware of these things. I think there is an evolution that more and more of these things are moving into the cloud, into distributed computing, where you don't have to maintain all of that on your own, you know, on your own just IT shop. So I think security is a large part. I mean, there's other cost drivers. I think security is a large part of what's driving that. I think there's also increasing encryption technologies so that if you do actually get at some of this information, that it's less damaging. So I think there's a conjunction of trends that are coming together, but there's clearly, and you know, the vendors, of course, do a huge amount of work here, right, in putting this out for their customers. So it's that combination of things. It is not perfect by, you know, any means.
Oh, do you see the ONC then, just to follow up real quick on that, do you see that ONC would be, if there's some kind of a breach out there, or there's something out there that can be patched, that you'd be putting information out there to say that, look, you've got to really get out there to make sure that this is being taken care of, because, this is an imminent threat with all these records out there, because again, a lot of folks out there are very, very concerned, of course, that what happens to those records once, as the practitioners are there putting it into the computer, all of a sudden it's out there then.
Yeah, actually, a lot of that happens at the level of HHS, right? So HHS has a cybersecurity process, a strategic operations center that is geared to do that. We're starting to work with a number of countries globally with their governments, their healthcare, ministries, and the folks there on information technology to think about how we get even more global rapid notification of these threats. So those are some things out there, but right now that is largely the initial response, right? Because these things sometimes have to be, pretty much instantaneous, is coming through the cybersecurity work at HHS and the command center there, just because of the scope. ONC has obviously we don't have a big operational footprint as a small staff agency to do that, so we rely on that broader set of HHS tools.
Thank you. Mr. Chairman, my time has expired and I yield back.
Chair thanks the gentleman. Gentleman yields back. Chair now recognizes the gentlelady from Colorado, Ms. DeGette. 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Rucker, when Mr. Upton and I worked on the 21st Century Cures Act along with this whole committee, one of our concerns was really improving interoperability of health data systems, because all these wonderful advances that we achieve won't be very useful unless we do that. And we also felt at the time that one of the least fleshed out areas of the bill, shall I say, was the interoperability and some of the health data. And we had hoped that we would be able to, frankly, be farther along now than we are in these areas. So I kind of I know you've been answering a lot of really specific questions that members have, but I'd like it if you can take it back out a little bit and talk for a moment about what the biggest impediments in general to a greater interoperability are at the moment, and maybe talk a little bit as we move into the 116th Congress about what Congress could do, if anything, to help ONC further the goals set out by Cures. Because again, I think that my colleagues on both sides of the aisle will agree, even though the leadership is changing, we still have a strong commitment to implementing this fully.
Yeah. So obviously I wish I could tell you that the rule had been passed through clearance, and so we could talk about the exact specifics of that rather than talking about it with a certain amount of generality. But there are some fairly specific things I can talk about that are part of interoperability. Why there's not interoperability is a very complex, multi-layered thing, and it frankly starts with the raw complexity of human biology, right? Unlike a financial transaction where there's a dollar sum and a destination and maybe a few other pieces of data to describe that, human biology, just think about the thousands of lab tests, all the different modalities of imaging, all the different narrative. It's immensely complicated, and most of that is not standardized. It's not really structured data. So there's an innate complexity there. Then you get into the business things, and you get into just the technology. It's worth noting, and I'm dating myself here, but the first couple of years I was involved in building the first Windows EMR. Right, so advice to anybody: don't build a software product in Windows 2.1. It'll crash during your demo for sure. But even years later, in Windows 95 was the first time there was even the TCP/IP internet stack that you could even communicate. Before that, and you all are too young, but for anybody who's listening on the internet, we had to do this like RS-232 ports and serial wires, right? When we wanted, there was no Bluetooth, there was no Wi-Fi. So I'm intimately familiar with that. I look at these things and I think a good analytic framework to take it to the top level. In Cures, there are two powerful components. One is the API, which means how do you connect to individual providers' records, right? So what is that endpoint where you connect to the record? The other is the Trust Exchange framework. What is the sharing network? Some cases make a lot more sense connecting to the record. Other cases make a lot more sense sharing. There may be hybrid approaches. So for example, Apple has a hybrid approach. So what Apple does is they have single point connections, and let me be clear. They broker actually a connection between the patient and their provider, providing security. Apple does not get that data.
So I hate to interrupt you,
Sorry.
Dr. Rucker, but because what you just described right here in 4 minutes of my 5 minutes of time is exactly what Mr. Upton and I identified, why it was impossible for us to be much more robust. What can Congress do going forward to not just identify the problem that you so much better than I can articulated, but what can we do? Are there legislative barriers to trying to overcome these burdens and to move forward?
I feel pretty confident that what has already been passed, when we have the rollout, will be, I think, very effective, increasing interoperability.
All right. Okay, great. Thank you. I love hearing that. One last thing. When can we expect the regulation to be released?
I do not have a specific date for you. As
Well, that's okay. Like time frame is good.
it is
We might
current.
release
It
it
is current.
because-
So it's currently in clearance with OMB. So I think that tells you that all of the text has been written, all of that has been done, all of the analysis that I think Congressman Green was asking about.
So soon, you think?
I am optimistic that it will be soon, but these are folks that are not under my control, so I don't honestly.
Thank you, Mr. Chairman.
Chair thanks the gentlelady. Gentlelady yields back. Chair now recognizes the gentleman from Virginia, Mr. Griffith. 5 minutes for questions, please.
Thank you very much, Mr. Chairman. First, I would be remiss if I didn't say thank you to Mr. Green for all the work that he's done. He has been willing to discuss ideas. We worked together on a couple things. Some of them were big. Our pharmacy, compounding pharmacy bill was a big deal, and I appreciate all that and appreciate your help on that. Likewise, I look forward to finding out what those rules are when they come out, as Ms. DeGette was just asking you. And, Mr. Chairman, I think this is an important hearing, but a lot of the questions have already been asked. Some will additionally be asked, and I'll be looking forward to listening to the answers to those at this time. However, I would yield my time to Dr. Bouchon.
Thank you very much for yielding. ONC's recently released draft clinician burden report acknowledges how information overload in electronic health records is contributing to physician burnout. I was a physician before I was in Congress. How does the ONC plan to address these challenges faced by clinicians? Would open application program interfaces help address some of the challenges by making electronic health records easier to use in a clinical setting? And let me just be brief about my own experience. I support EMRs. We put one in our medical practice in 2005. I wouldn't want to go back to paper charts. It's a major advance, but we have challenges, as we've heard here today. One of the big ones I'm concerned about is the physician burden. And so if you would address how that the ONC plans to address the physician challenges, I'd appreciate that.
Yes. To get to the very specific part, we do believe that having better, more robust application programming interfaces will make it easier to get data on patients. So when you get a referral patient for your practice or send somebody to another provider, that will be materially easier. We've made a lot of progress there, but the progress has been patchy. In terms of the burden, there are a number of areas that we are working on. I mentioned documentation, which is, I think, one of the biggest areas. We're doing a number of things on usability, working with the vendors there on that. We're actively engaged in ongoing discussions with CMS on are there other things we can simplify in the CMS stack which, as you know, includes quality measures of a vast type of varieties. CMS is working on a clinical quality language to try to make that whole process less burdensome. An area that we're working on internally and with CMS and outside stakeholders is on prior authorization, which is another big thing that has been extremely problematic for everybody. And the thought there is, can we use interchange standards so this is not having your office waiting on the phone with a payer, you know, for who knows, for some cryptic, ill-defined set of information that you don't know ahead of time to decide whether something is authorized. This is bad for patients, it's bad for providers. So those are some of the areas. We're happy to get into much more detail in these 5-minute slots.
Yeah, it's a complicated problem.
We can't even begin to go in the nuance, but
can I express one concern about code consolidation, you know, and simplification as it's been promoted for the physician community, as you probably know, has concerns about code consolidation, even though going from 1 to 3 codes, for example, something like that, as the different billing levels, there's a specific concern that very complicated patients that currently bill a level 5 now would be a level 3, but that the reimbursement wouldn't be consistent with a level 5. So we'd have physicians specifically that see very complicated patients are very concerned about that, and I know you're aware of that situation. I've personally voiced that concern to Administrator Verma, and I think they understand that. But it's very laudable what they're doing. They have, as you know, patients before paperwork program that goes through a lot of these things. You know, the challenges that we have today are obviously security and really and interoperability. The only way I see that you totally secure a patient's medical record is you never put it on a computer. But we're not obviously going to do that. Are you talking about broader educating people that utilize the computers, including staff and physicians, on proper password management? And, I mean, basic fundamentals, right? And if you look at cybersecurity, the first thing is the first step is the user and their password stuff. So what are you all doing to try to, you know, there's obviously big things we can do on cybersecurity. What are you doing to fundamentally educate people that access the system on how they protect their information?
Right. So, you know, to mention briefly, obviously we have that as part of the promoting interoperability program with Medicare, just so that, you know, folks at least have one exposure to doing that. We've done work with the Office of Civil Rights on educating patients on that.
So my time has expired. So if I'm fine with a written response to
we'd be happy to provide you with a written.
Send that to the committee.
We'd be happy to provide you with a written response on that.
Thank you. I yield back.
Does the gentleman from Virginia yield back? Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentlelady from California, Ms. Eshu. 5 minutes for questions, please.
Thank you, Mr. Chairman, not only for having this hearing today, but for your service as chairman of this subcommittee. We all salute you for the work that has been done. And even though Gene Green is not here, I want to acknowledge his work with you. I think that you've been an excellent pair of leaders of the subcommittee. And Gene and I were classmates. We came in the same year, so thank you to both of you. Dr. Rucker, welcome. I can't help but think that that I'm listening to someone whose job I created, because I did the legislation to establish the Office of a National Coordinator of Health Information Technology. That was signed into law as part of the American Recovery and Reinvestment Act, 9 years ago, in 2009. Now, the legislation also addressed, as you know, electronic health record interoperability. And I think that you've heard from just about every member that has questioned, made comments, that we're still having issues with it. We don't have a seamless system of interoperability in our country. It seems to you've talked about many things that you'd like to look at or that you are looking at, but it seems to me that you're testifying today in a state of limbo because the rules have not been written. So it's, I think it's a little awkward, I think. But nonetheless, we can still ask you whatever questions we want, right? I'd like to, you mentioned in the, in your testimony, in your written testimony, Apple's Health Records app. Now, I've seen the app, obviously, firsthand. I think it's a very exciting concept, and I think it's important for patients to be able to access their health data, but that requires health systems to make their data available, and it also, going back to an issue that's been raised by just about every single member, it introduces the need for additional privacy and data security. So I just want to ask you a direct question. How are you, as the director, going to address this?
So,
Not how you think you might or what several
So-
ideas are. Do you have
so-
a specific
Yes.
answer to the specific question?
yes, so the
Thank you.
upcoming Cures rule will specifically address the security requirements for what you're referring to, which is the application programming interface that providers need to provide. It's going to be part of the certification process for electronic health records, that API exists, and we're designing it in a way to use industry standard API technology to maximize security. So those are very specific things with very specific technology. We have to the earlier part, I probably had 150 stakeholder meetings and been out on the speaking circuit. So we've actually already made a fair amount of progress in getting people to understand the concept of open APIs. Some of the large vendors have opened up their APIs in response to the Cures Act. We're seeing a lot more network sharing, which I believe, when you look at the temporal sequence of events, is based on the upcoming Cures Act rulemaking. So even as we speak, the Cures Act has had a significant impact on what you're
If you were going
describing.
to grade interoperability when it comes to electronic health records in our country, what grade would you give it?
It's highly patchy, which is the problem. You know,
Oh,
there's
just what
A
grade
students
would
and
you
there's
give it?
F students.
Patchy is not.
Right, so I guess
There's
maybe it
A, B,
averages out
C, and
to
D,
a,
not a
maybe
P.
it averages out to a C minus, but it's
And
an
when was
average,
the
it's
last
an
time
average.
you had any communication from OMB? Are they the ones that are, who's writing the rule? It's not-
ONC is right.
ONC?
ONC is writing the rule.
I see. Is there anything that you think is missing from the legislation that you need relative to implementation?
I have to be honest, I was surprised at how thorough it was when I actually read it and took the position. You know, I obviously hadn't read it in great detail before. I was amazed at how thoughtful it was and how well put together it was. And, you know, I was extremely pleased coming into the national coordinator, and I want to thank, frankly, my predecessors, because I know there was a lot of technical work and a lot of technical support with my predecessors under the Obama administration, working with Congress to support Congress in the bipartisan way and putting that together. So I think I was pleased, and I think we've accomplished something in a bipartisan trajectory.
Thank you. Merry Christmas.
Thank you.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Missouri, Mr. Billy Long. 5 minutes for your questions, please.
Thank you, Mr. Chairman. And there's Gene Green back. I just want to echo what everyone has said about my buddy Gene. We're going to miss you and Helen, and thank you for all your years of service to Congress, to the committee, to the folks in Texas. You're going to be a big loss for us. Dr. Rucker, when Obamacare first went into effect, I happened to have an appointment with my doctor shortly after that, and I went in and I thought I was going to have to prescribe him blood pressure medication for the amount of paperwork that he said, you sit there, and I've got to enter all this in the computer. I have to, and he was so upset about the burdensome paperwork. Shortly thereafter, he decided to take early retirement. He just said, I'm out of here. He wasn't at retirement age, but he just had all the fun he could stand. And when I talk to physicians, they mention how overly burdensome their paperwork requirements are and how too much of their time is spent on data entry instead of seeing patients. He calculated he lost 1 day a week of seeing patients because of the amount of paperwork he had to do. So instead of seeing patients 5 days a week, in essence, he was seeing them 4 days a week. In November, ONC and CMS released a draft strategy on reducing regulatory and administrative burdens. What do you think the main driver of this burden is, and what would...
In working with CMS on that report, I think in deciphering out just some of the times, the time component, a lot of people have told us it's over a day a week. It's over 20%. In the order of 3 or 4 hours a day. I think 20% would be on the low side. I think, to me, the biggest area to start with is documentation. So because we're gating fee-for-service through the CPT billing codes, they have a bit of what in a Pavlovian psychology thing could call an aversive stimulus. If you want to get paid more, you have to deal with more of this burden. I think that has caused huge dissatisfaction. I've worked with thousands of doctors. In the ER, it's sort of a communal pit. You hear what everybody says. I know, in talking with thousands of people, they hate this. It's very hard for us to teach this to the residents. They look at us like, are you out of your mind? Literally. So that is a big issue. Prior authorization, we're here. That's a little bit more specific to the types of practices. Is a big issue. We've heard quality, some of the quality measure reporting, very expensive and time consuming. And frankly, we're getting an early signal, and we're doing a lot of work at ONC to try to make sure that the prescription drug monitoring programs don't become an additional burden. They're required pretty much in every state. And often that means you have to get out of your computer, log onto another computer, get out again, document it. That's a lot of time on a go-around, right? Because you know how long it takes to log onto a computer, even if you can memorize all these passwords. So we're doing some work to sort out, and I know a number of people are working on integrating PDMP into the record so that we're not adding additional burden inadvertently as we try to solve the opiate crisis.
So are there health IT system usability problems?
Yes.
What are some of the key recommendations from the strategy, and how can we reduce the overall burdens on clinicians?
So key recommendations from the strategy, we discussed documentation, we discussed prior auth. There are some things on usability. The Electronic Health Records Association, the Vendor Association, is working on standardizing some things, even small things like what is the order results? Is it the most recent result first? Is it the first result first? Even some simple things like that. The APIs in terms of getting the programming interfaces to get data from other providers is going to be a big thing. The quality group at CMS with whom we work with quite intensively have a number of programs they're working on to make quality measures more responsive, more real, and simpler. We've worked a lot with CMS in just the payment rules around, what used to be the Electronic Health Records Incentive Program, what is now promoting interoperability. Seema Verma has been very aggressive in pushing everybody she can get her hands on, that includes me, in terms of making things easier and working with CMS to do that. So a number of things are in progress.
So you're working with stakeholders in developing these strategies?
We've had meetings with about 150 stakeholders, and many of the meetings have been on burden.
Okay, Mr. Chairman, I don't have any time to yield back, but if I did, I would.
And the chair appreciates your willingness. Chair now recognizes the gentleman from New York, Mr. Engel. 5 minutes for questions, please.
Thank you, Mr. Chairman, and I too want to express my chagrin that Gene Green not going to be here anymore, but I know he's going to be doing some great things and with some time, spare time with his wife and with Helen, and just want to tell everybody how much we always sat next to each other, and we're going to miss you. I would attempt to do it, but I would just make a fool of myself. Thank you, Dr. Rucker, for being here today. As you know, in May, the GAO issued a report on the challenges patients and providers face when it comes to access to medical records. And I'm particularly concerned about this finding in the GAO's report, and I quote it: "Patients' challenges include incurring what they believe to be high fees when requesting medical records, for example, when facing severe medical issues that have generated a high number of medical records. Additionally, not all patients are aware that they have a right to challenge providers who deny them access to their medical records." So, Dr. Rucker, let me ask you, is ONC doing anything to help mitigate the costs that patients face as a result of this?
Yes, by law, the electronic access to records is something that should not be charged for. The open application, the application programming interfaces under CURES are designed, and our rulemaking will implement that patients can direct their smartphones at the provider's endpoint, the URL, if you will, and download their records and do it in a way that is convenient to patients. They can aggregate records from other providers. We believe there will be apps to do that. Apple already has one. There are smaller companies that have these apps out there now. We believe this line of business will grow. It'll add value in all kinds of ways. But I think the key practically is charts, the printouts of these charts. Now, if you get a, quote, printout from one of these electronically generated charts, it's hundreds of pages of stuff that is impossible to read for a physician, let alone a patient. When you're on the inbound side of this in referrals, it basically jams up the laser printer fax machine. At Ohio State, where I worked, I'm told by some of their staff, they would get 90 calls a day where inbound faxes were so large that they jammed up the nursing unit's fax server, which are, the laser printers on the unit. Smartphones are powerful computers that I think are exactly what we need to get patients their records and to do it in a way that patients can control their care and, frankly, shop for their care.
Well, doctors who can't read it know how the rest of us feel when we try to read doctors' signatures or doctors' notes. What about patient education? Is anything being done to ensure that patients know that they have a right to access their medical records?
We've worked with the Office of Civil Rights on an ongoing basis, I think over a number of years, to describe for patients how to get their information. Now, some of this is consumer marketing. We don't have a budget for consumer marketing, but to the extent that we are able, we're encouraging that, and we believe that with the open APIs, there's going to be a lot more public awareness of the availability of this, because right now, that is these simple things aren't available, so it's hard for people to learn about them because what they would learn about is so complex.
Thank you very much. Thank you, Mr. Chairman.
Thank you. The gentleman yields back. The chair now recognizes Mr. Bilirakis for 5 minutes for questions.
Thanks so much. Dr. Rucker, high-tech made available over $35 billion to modernize HIT infrastructure centered on the meaningful use of certified EHRs. These incentive funds were designed to assist eligible providers to purchase, implement, and maintain EHR systems, as well as meet criteria to advance reporting on quality indicators. While the implementation of the high-tech was far from perfect, it was the launching pad for the implementation of EHR ecosystem we have here today. Yet, certain provider types, such as behavioral health providers, were not eligible for this incentive funding to build out electronic health platforms. Meanwhile, today, as a result of the opioid crisis and increasing suicide rates in the U.S., we are increasingly aware of the importance that behavioral health plays in whole person care, health care. Given that behavioral health was carved out of high tech and serves as a critical linkage to integrated care, what, if any, plans exist to cross this bridge?
Well, I think there is, first of all, a start with the Center for Medicare and Medicaid Innovation in the SUPPORT Act, the recent Opioid Act, to look specifically at the question of behavioral health records. I think one of the big opportunities we have is to use these regional health information exchanges to share even the simplest of data on patients with behavioral health and substance use issues. The data I'm talking about, because as an ER doc, you see these people, they float in and out of the system. They float from group homes, shelters, all kinds of situations. Simple AD, in some parts of the country, health information exchange, you use simple ADT. ADT is admit, discharge, transfer. So all it says is, where was this person? Where are they located? That simple information often helps to coordinate some of this care. So there may be a very low-hanging fruit here that is worth looking at, and we are looking at how to expand that to get at the behavioral health issues. Part of the challenge is a lot of these folks, as you pointed out, don't have software per se, right? So, but to the extent they do have software and any ability, this is the sort of the simplest common denominator that we think, and we have some anecdotal experience, is going to be very powerful for helping these folks. I've taken care of a lot of these folks over many, many, many years. So I'm pretty excited about trying to do something in this role.
Thank you. Next question. What is ONC doing to enable physical therapy and other non-physician EHR vendors to satisfy certified EHR technology requirements?
Yeah. So for the broader healthcare ecosystem, we the biggest thing we do, in areas where we're not per se certifying for the non-certified part of that world, is a lot of work on standards, right? So people can share information, have lower costs of getting information, providing information, entering information. We are do a lot of standards work. We actually summarize it with an interoperability standards advisory, which is a constantly updated database of the best standards in healthcare. We have used resources to encourage some of these standards. We do a lot of work with a number of the standards organizations, most specifically HL7, and we've also supported some of the deeper technical things needed to advance standards to make the communication across the healthcare board more efficient.
Okay, I guess I have a couple more. You know what? Let me just go ahead and submit them for the record, Mr. Chairman, in the interest of time. Thank you.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentlelady from Indiana. Ms. Brooks, 5 minutes for your questions, please.
Thank you, Mr. Chairman. Thank you, Dr. Rucker, for being here. But I also want to add my thanks to Ranking Member Green. As fellow Texans, you two gentlemen have led this subcommittee so admirably. We've gotten so much done, and we're really going to miss you. With that, Dr. Rucker, I want to elaborate a bit more on the use of smartphone-based apps and obviously your desire to continue to advance that. Are there any additional regulatory changes that would be helpful in further accelerating or incentivizing health record applications?
I think we're in a very good position with the Cures Act language on that. I think when the rule comes out, and there's obviously public comment and that whole annealing process on the rule, I believe we're going to be in a very good position to have accomplished that. So I'm very confident. Predicting the future, obviously, hard to impossible, but I feel very confident that the language that Congress has put in that and that we're implementing will do a lot there. I think modern technology is very helpful. Having the API stack that the rest of the smartphone economy uses and starting to move healthcare into that is going to be very powerful. And, you know, so that allows healthcare to ride off the development of all of the rest of the app economy, right? Historically, part of the challenge of interoperability is we've done it all ourselves with one-off healthcare protocols. You know, if you go to any other computer person and you show them, they're like, what? Right? I mean, there's just befuddlement. We're trying to move healthcare with the, you know, with the fast healthcare interoperability resources, the so-called FHIR, into the modern economy stack. We're mindful of the work that's been done, the sharing that's going on. We want to, you know, support and acknowledge that, but over time, and certainly for the smartphone part of it, we believe that's the way to go.
So I'm hopeful that the new rule that is coming out will address maybe barriers to the app development, but how about with respect to utilization? How about with respect to getting average citizen to begin using it? What comments do you have about what we could do to either incentivize or to encourage its use?
To me, the absolute, as somebody who's built computer software, the only thing that counts is how easy is it to use. How many clicks, how much reading, how much thinking do you have to do? Ease of use is everything in consumer apps. Everything we do in our rulemaking is geared to encouraging ease of use. Now, as all the other questions have pointed out, you have to balance that against security and privacy, so there's an inherent tension there. But with what we think is an appropriate balance, that's our focus.
But these types of apps that are being developed and that are in development and with the rulemaking, they are approved by your organization, correct?
No.
Okay. Should there be some additional approval process on the app development necessary to, you know?
Right. So these apps are not approved by us or by the FDA, you know, in the current go-around. I think we want to be very, very careful that we don't have further burden on innovation. This is a fast-moving part of the economy. I know in working with the White House, we're trying to get investment in this, highlight the investment opportunities. The Office of American Innovation has been heavily involved in that outreach. So I think we're trying to encourage people to enter this space. I think regulating it a priori, I don't believe is going to be a public, I don't think that's going to get a public value, because I think it's actually very hard to regulate the privacy and security breaches that are coming, because a lot of that is the law of unintended consequence.
I recently saw a study that Johns Hopkins did concluding that more than 250,000 people in the U.S. die every year due to medical errors. And then also we obviously know about all of these duplicative tests that can often happen. Do you believe that access to mobile health records will help reduce this number?
I think it will, because I think it allows further clarification. I think better APIs. By no means the only reason for medical errors, but clearly a part of it is just the complexity of what we have out there. Any technology that makes it simpler. Patients are probably the best check on what's going on for their care, right? They're presumably the most interested in it. So having them be able to say, no, I'm not on that med, or, you know, why did you put this diagnosis down? I think that transparency is essential. I think the Cures Act provides a vast amount of transparency to patients in healthcare. So I think that's very powerful. The more eyes you have on a problem, I think the better it can be.
Thank you. I yield back.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Oklahoma. 5 minutes for your questions, please.
Thank you, Mr. Chairman, and I also want to thank my colleague from Texas, Mr. Green. It is.
All right, yeah.
It is, but football season is over, and we won, so that matters.
Somehow I thought that might come up.
Yeah. Anyways, Mr. Green and I, we have worked together probably more than any other person on the other side of the aisle, and he's going to be missed. He's one of the rare ones around here that sees it from a perspective, not from a party perspective, but from his perspective. So I really enjoy working with him. You know, let's talk. We've talked a lot about privacy, and I have a bill out right now, HR 6082, which has to do with realigning Part 2, and helps with, in my opinion, the provider getting the information they need. My colleague from Indiana just brought up that there is obviously a need for doctors to get more adequate information about the patient. Do you feel right now with 42 CFR Part 2, with them being realigned outside of HIPAA, do you think that hinders the provider from getting the adequate information on the individual?
Well, as you know, that it is a very controversial. We've had a number of people lobby, come to us on both sides of that coin. I'm going to defer to my colleagues at SAMHSA and the Deputy Secretary. I know the Deputy Secretary is reading a regulatory sprint for coordinated care, looking specifically at the issues around 42 CFR Part 2. So I'm going to, because they're the primary agency, I think I'm going to defer to them on that.
I read in your agency's draft clinician burden report published last month that the healthcare providers struggle to navigate health IT privacy regulations governed by 42 CFR Part 2. Is that correct?
Yes.
So what exactly do they struggle with then?
Well, we've heard as the struggles are around knowing when, I think one of the big struggles, there's some others, but one of the big ones is knowing who's actually covered. So the technical language is that providers who provide a specialized class of substance use treatment are covered. But if you're part of a larger entity, right? So if you're a big, delivery system, who's covered, right? Is that psychiatry? Is it just that practice? Those boundaries are very hard to navigate for folks. That boundary and that description generates, and so people default to just saying it might all be covered. Nobody wants to risk it, and so
does Part 2 strengthen the patient's care or worsen it then?
I think that, again, I'm going to defer to SAMHSA. I think we'll have some data on that. I want to be.
Well, we already know that there's been accidental deaths because of Part 2 not aligning with HIPAA. Mm-hmm. We're talking about the patient, and we also talk about privacy too.
Yeah.
But through HIPAA, individuals with heart disease or HIV, do you think they're adequately covered through privacy through HIPAA?
I think HIPAA does a great job with privacy.
So, in your opinion, then, is it right that we separate individual with mental illness or disorders or abuse disorders separate from anybody else's care?
Well, I think there's a overall goal to get those things integrated, to have what sort of folks call holistic care. The specifics I'm going to defer to the specific agency that handles that, but I think there's an overall desire to have integrated care. I think that's just good patient care. All of these things blend together.
One last question then. How difficult is it for a provider to access Part 2, and what risk comes along with that?
Well, I think that the difficulty is not in the access. It's the difficulty is in the availability.
They can't just access it. They got to get the patient's. They got to get the patient's permissions, right?
Yes.
So they have to get HIPAA permission, and then they have to go one step further, and they have to ask for that, right?
Yes.
So if the provider has no reason to ask, doesn't that create a problem right there?
Potentially, it does.
Now, what if the patient shows up in the emergency room is unconscious? How many providers automatically access Part 2?
I do not know the answer to that. I can see if there's information on that. I do not have information on that. As a practical matter, in the emergency department, if they're unconscious, we try to treat them immediately.
Well, I know,
and
but
part
you-
of
but
that
you're
will be
treating if you
giving
got
Narcan.
also- yeah.
Part of that will be an assumption for many patients, far more. We will assume in many cases that there is an opioid, and a standard part of that treatment is to administer Narcan or some version of that, on the possibility that that might be the cause. I mean, we administer things like glucose on the thought that maybe the person's hypoglycemic as well.
So do you think it would improve the patient's care if we could align Part 2 and HIPAA?
I think alignment there, I think that would be helpful.
Thank you. I yield back. Thank you, Mr. Chairman.
Gentleman yields back. The answer to the gentleman's question is yes.
From both sides of the aisle.
Chair recognizes the gentleman from Georgia, Mr.
Only
Carter,
the
5
Senate
minutes
would
for
see it that
question.
way.
Thank you, and thank you for being here. Excuse me. I just want to begin by adding my voice to those who have already talked about the proposed rule on information blocking. And just, it's obviously very critical. We all understand that. But I just wanted to see if you could give me an update. I understand it's out of your hands right now, and it's with OMB. Is exactly where they're at with it. Do you have any idea when we could look forward to seeing that?
I wish I could give you specifics. I think they're looking at it. I think we'd have to defer to them to things. I believe we are close on that. I'm not aware of any insurmountable difficulties or challenges, but I think there's a large checks and balances process here that is part of the way things work, our democracy. And I just, as somebody who's in a staff agency, I just have to be mindful of that. Believe me, I share your frustration. I share your frustration. I wish I could tell you exactly what's in it, tell you it was all done, but unfortunately I can't.
Do you have any idea what's in it? I mean, have you?
I have read it multiple times. I have a very precise idea of what's in it. We've had vast number of discussions with Lisa Anthony, who heads our rulemaking group. I'm intimately familiar with the details. Many of the details are quite challenging to put together, and to reflect on the complexity of the American healthcare system. So yes, I'm very familiar with what's in it.
But I'm hoping you're optimistic that it's going to help.
I'm extremely optimistic.
Okay, good. I'm glad to hear that. I wanted to ask about health provider documentation and the documentation burden. We're all aware of that. In fact, you mentioned in your testimony the ability to address clinical burden and how burnout especially has been impacting healthcare professionals. Can you describe some of the efforts that have been made to relieve some of the administrative burden?
Yeah, so in the burden report there that we've jointly done with CMS, there are a couple areas that we're working on. We've discussed simplification of documentation. So one of the specific things, for example, is if you already have a past medical history that hasn't changed or a family medical history that hasn't changed, you do not need to re-enter it again, would be a very specific thing. If you have, for example, a resident or a medical student who spends a lot of energy getting a history, you do not have to redocument all of that so that you then have to read it and wade through that much more text on it, some very specific things. We talked about the prior authorization and work on the technology that might make that a lot simpler. In the promoting interoperability, there's working with CMS, we've simplified a lot of the provisions around that, tried to sync up between outpatients and inpatients so these aren't two diametrically opposed things that read differently. If you cross the threshold of the hospital door, I mean, quality and interoperability shouldn't change because you walked 1 foot into the door, through the door. So
what kind of feedback have you gotten? Has it been positive?
I think we've gotten positive feedback on a number of things. On the documentation, as Congressman Bouchon mentioned, there were concerns and maybe not a full understanding of how complexity would be paid for, right? You know, how the sickest patients, how the economics of payment for that would work out. There are a number of provisions in there on that. And I think folks also didn't, frankly, calculate the amount of money spent on billing to, you know, work these codes through the process. I mean, the overhead practices, I think, are spending between 5 and 10%, maybe more, of their revenue on billing through these complex coding systems. Much of that is a dead loss to the economy and to the American public.
Absolutely. I'm glad you recognize that, because that is one of the most frequent concerns that is voiced to me, is just how much it's taking financially for them to adhere to this. So I'm glad to hear you say that. I'm running out of time here, but I did want to ask you very quickly about the EHR reporting program, and I know an RFI was issued for that and released, but there were budgetary concerns. Has that been handled, or you?
Well, working within the budget we've contracted out with somebody to start the process of putting, that construct together and sorting out what information can be asked to do EHR reporting, with the goal of giving providers more information on their electronic health record potential purchases.
Any other hurdles, any other barriers that you've run into in order to implement this?
I think we're early enough on that we probably haven't hit the hurdles. The budget is such that we will, it's not going to be a comprehensive survey of the entire United States just within the constraints of the budget. But I'm confident we're going to get some valuable information that will help folks.
Okay. Well, thank you very much, and thank you for your indulgence, Mr. Chairman. I yield back.
Chair, thanks the gentleman. Gentleman yields back. I'll now yield myself the balance of the time for questions. Just testing you. I'll miss you too.
Not as much as they will, though.
How can I miss you if you won't go away? Dr. Rucker, in preparation for and I do thank you for being here, in preparation for this hearing, and we had a long time to kind of consider because we've waited for this rule, and we kind of ran out of years, so we had to get the hearing in ahead of the rule. But in preparing for this, reading in the Annals of Internal Medicine from November 12, 2018, an article by Atul Gawande, Why Doctors Hate Their Computers. And let me first stress that I rarely agree with Dr. Gawande on everything, but he does write a paragraph here that I just really thought summed up what our hearing is about today. He says, "Something's gone terribly wrong. Doctors are among the most technology-avid people in society. Computerization has simplified tasks in many industries, yet somehow we've reached a point where people in the medical profession actively, viscerally, volubly hate their computers." End quote. True statement, yes or no?
Yes.
Yeah, it is, and we hear that. I heard that when I was in Mr. Lada's district. Heard it from both doctors and people in the hospital and medical staff section. Now, your office and the Center for Medicare and Medicaid Services talks about sharing the goals of reducing physician burden. So, can you give us an idea how you are working with CMS along those lines to reduce physician burden?
Yeah. I mean, I think the root of that problem, and I agree with what was in that article, is that these EMRs have really first and foremost grown up as billing systems, right? There's been no automation.
Bingo. That what he called the tyranny of the ancillaries.
Yes. So, it's striking to me as somebody who went into this field. I did a computer science degree coming straight out of residency. I wanted to automate stuff so I didn't have to do SCUT, which is the, slang word for non-value add work that seems to be the bane of residency training. That was my goal. I worked in an era when the entire hospital's microbiology results were randomly reported out non-alphabetized you had to read through every single culture result in the entire hospital to find out if your patient had a urine culture done. So that was the world. As we've discussed, what we're doing with CMS is trying to be systematic about addressing these things. And so you've seen a couple things. I mean, one I want to highlight is the Meaningful Use Program, I think, trying to be a steward of the $35 billion, wanted to have a lot of controls on, is this a full and complete electronic health record? I think we've done that. And now we're really focusing not on that, but on just sort of the interfaces and the burden. I think there's still work to be done in documentation. Some of that is related to fee for service. Some of that in alternate payment mechanisms would go away. I think there's a lot of work to be done in prior authorization that, so I think there are a number of areas.
May I ask you a question about that? You keep bringing up prior authorization, and one of the banes of my existence when I practiced was dialing 1-800-California to get permission to do something that I knew was clinically indicated. So it seems like that should just follow then from the data in the electronic record. So if an asthma drug is indicated, or a surgical procedure, or an imaging procedure, it should just follow then from the data that's already there, correct?
Yes, the hope is that these APIs will in fact be efficient enough in exposing that information that these transactions can be greatly simplified. The delivery of the information can be made bidirectional, so that that whole loop of being on the phone is minimized or goes away. And that may even be a paradigm.
I prefer goes away, and only then interacting with the doctor if there is some question as to whether the documentation is complete enough or fulfills all of the requirements.
Yeah.
That seems like that would be a laudable goal. I've got other questions, and like others, I will submit for the record, and I do appreciate your time. I understand we do have a hard stop, so I'll yield back the balance of my time, and seeing no other members wishing to ask questions, I do want to thank Dr. Rucker for making time to be here today. Again, it's been a long time coming. We've wanted you here on several occasions, but we got you now. So I would like to submit documents from the following for the record: College of Healthcare Information Management Executives and the American Society for Clinical Oncology. Pursuant to committee rules, I remind members they have 10 business days to submit additional questions for the record, and I ask the witness to submit his response within 10 days of receipt of the questions. And then I will just add my voice to the others on the committee. It's been a privilege working with you, Mr. Green.
Most of the time.
Most of the time. We actually have done some very good work this past 2 years, and it has been a very active session of Congress on the Health Subcommittee. I am not going anywhere, so no one will have to miss me, but we will miss you and wish you success in your future endeavors. With that, Dr. Rucker, again, thank you, and the subcommittee is adjourned.
Thank you, Mike. We have to be on the floor now at 12:30.
Yeah, I know.